J'ouvre maintenant la séance. Welcome to meeting number 135 of the House of Commons Standing Committee on the Status of Women. To all members, please wait until I recognize you by name prior to speaking, and a reminder that all comments should be addressed through that of the chair. Thank you in advance for all of your cooperation. Pursuant to Standing Order 1082, and the motions adopted by the committee on Tuesday, June 4th, 2024, and Wednesday, September 25th, 2024, the committee will resume its study of breast cancer screening for women aged 40. At this point now, I'd like to welcome our witnesses, all appearing by video conference this morning. Canadian Indigenous Nurses Association, Dr. Angeline Laton, Vice President. Alethea Kiwayash, Director, Indigenous Cancer Care Unit and Indigenous Health Equity and Coordination. Dr. Amanda Shepard, Senior Scientist. Branch of Hope Cancer Support Services, Juliette Danielle, Professor. University of British Columbia, Dr. Nadine, Health Authority Chair in Cancer and Wellness. All of you for today's discussion so that we could have additional commentary. At this point, we will begin with opening statements. Dr. Laton, you have the floor for up to 5 minutes.
Good morning. Very happy to be here to be able to speak on this really important topic for Indigenous women and men across Canada. About 10 years ago, I recall attending a national cancer conference at which the researchers were reporting on links between diabetes type 2 and breast cancer. I believe those linkages and research have grown since that time. The importance of breast cancer among these populations then becomes even more critical when we begin to think about possible linkages between other comorbidities. So with First Nations women in cancer, these rates have steadily increased, and of course, we have significant issues that impact outcomes, which include late-stage diagnosis, which leads to poor options and choices for treatment and more deaths from the disease. In Alberta, we've done a fair amount of research in terms of looking at the data on different cancers, including breast cancers. And so what we found is that First Nations women, when compared to non-First Nations women in Alberta, are almost 24% more likely to have a breast cancer diagnosis, and they're certainly more likely to be diagnosed with an invasive cancer at stage 2 through 4. We've also found that it's taken 2 to 4 weeks longer for First Nations women to receive their first diagnosis, as well as a definitive diagnosis when compared to non-First Nations women. What this leads us to conclude is that collectively these findings suggest that access and provision to screening services for First Nations women may not be equitable when compared to non-First Nations women. We've also done some work with Métis women in Alberta, and cancer continues to be a leading cause of death amongst this population. So programs, of course, can detect cancer early at the most treatable stage, or when precancerous lesions can be noted. And this can contribute to cancer outcomes and decrease cancer mortality, incidence, and morbidity. So in Alberta, cancer prevention screening programs, of course, are available for breast cancer and are publicly funded through the Canada Universal Healthcare System, And despite the availability of these screening programs, we are still noting disparities in cancer screening for breast, colorectal, and cervical cancers. Um, and we also believe from our research that some of these disparities can be addressed by leveraging the experiences of Indigenous women and peoples to inform the development of more meaningful interventions that reduce these disparities. So, because breast cancer appears in Indigenous women at higher rates for both First Nations and Métis women, we need to be looking at distinct Indigenous services or services that meet the needs of both of these populations. So, according to a 2024 publication, in some research that I was involved in, both cervical and breast cancer screening outcomes about among Métis women were shown to be less than those of non-Métis women. This is really leads us to the fact that we need to have more studies across Canada and certainly within Alberta that look at breast cancer rates among the Indigenous distinct populations to really get a better understanding of what's going on with Indigenous women and breast cancers. So I think when we start talking about outcomes and needs going forward, there's definitely more work that is needed in this area. We need to raise awareness around prevention and screening. Most of my work really is in prevention and screening, and it's becoming more evident that we need to shift the thinking and the knowledge that Indigenous women have when it comes to breast screening, and it needs to be seen as a healthy lifestyle choice and something that you regularly participate in and not just an action that you take when you believe that there's an issue or a problem. Of course, there's many issues that underlie that. Some of them are related to Indigenous women and having regular access to a primary care provider, right? And this really depends on sometimes the area that you live in, and of course, trust, racism, all of those factors uh, come into play. So, thank you.
Next, I would welcome Alethea Kiwiash, Director, Indigenous Cancer Care Unit and Indigenous Health Equity and Coordination. Please go ahead.
Thank you for the opportunity to appear before the committee again. Joining me is Amanda Shepard, Senior Scientist for the Indigenous Cancer Care Unit. When it comes to breast cancer and Indigenous women, recent data suggests lower participation in breast cancer screening among First Nation persons in Ontario. First Nation communities in Ontario have raised concerns about cancer diagnosis at younger than screen-eligible ages and difficulties accessing screening. The Joint Ontario Indigenous Health Committee shared these concerns with our team and provided a recommendation to apply for research funding to learn more, a recommendation we are looking into. What we have found are that trends in getting and dying from breast cancer have improved over time for First Nation women in Ontario. However, once a First Nation person got breast cancer, they had a lower chance of surviving compared to other Ontarians. Specifically, First Nation women are 41% more likely to have died 10 years after their cancer diagnosis. Descriptive data also reveal First Nation women were diagnosed with breast cancer 4 years younger than other women in Ontario, and the interquartile range started at age 48. Research today has highlighted the breast cancer experience of First Nation women in the context of screening those aged 50 to 74. We do not have the data to describe the benefit of screening commencing at age 40. Therefore, research is required to learn about breast cancer prognosis among Indigenous women aged 40 to 49, and to better understand how a cancer screening program can be tailored to best provide equitable access to screening in this age group. As outlined in my November 18 presentation to the committee, the Ontario Breast Screening Program is a province-wide screening program that aims to reduce breast cancer deaths through regular screening. The program offers screening to two different groups of people who qualify for breast cancer screening. People aged 50 to 74 at average risk for breast cancer, and this was expanded to include age 40 to 49 as of October 8, 2024, and also people aged 30 to 69 at high risk for breast cancer. Indigenous adults are often under or never screened when it comes to cancer screening. There are many reasons for this, including intergenerational trauma, social determinants of health, and specific to health and cancer care, stereotypes and prejudice, communication barriers, need for translation services, lack of trust for the medical system, no primary care provider, poor coordination of care, jurisdictional issues between the federal and provincial governments, racism in the healthcare system, transportation issues, not having a valid OHIP, and there are many others. We need to do everything we can to ensure that Indigenous women have the same health outcomes as other women in Canada. Recently, members of my team were invited to two remote First Nations communities in Northern Ontario to talk about cancer screening and preventative health care. Almost every single person they met in those communities had been personally affected or had a first-degree relative affected by cancer. The major issue that was flagged was that community members do not have access to health care in a timely manner. The Non-Insured Health Benefit Program provides medical transportation for eligible First Nations and Inuit clients who are traveling out of the community for a range of health benefits, including breast cancer screening and follow-up. We have heard directly from community members that issues with NIHB medical transportation is one of the main factors in accessing health care in a timely manner. Lately, there have been significant delays in booking travel for appointments, including mammograms and associated follow-up, which is causing patients to miss appointments. This is especially a concern when the appointment is for a mammogram and leads to a later missed cancer diagnosis or a specialist appointment that the community member will now have to wait 6 to 12 months to reschedule. We heard from community members that when they have to wait such a long time for a rescheduled appointment, they often choose just not go. As a result of all of this, we heard from community that people they know are being diagnosed at later stages and were choosing not to get treated. There's also a large Inuit population and none of it. However, there is no breast screening in the territory. The current process is for Inuit women to be flown to Ottawa for mammograms. As a result of this, it was noted that mammograms are typically only requested when an Inuit woman finds a lump. At this point, the woman would be sent for diagnosis testing and not a mammogram. Early detection should be easier to access to ensure that Indigenous women can access breast screening at younger age so we can catch cancers early. To reduce barriers and support First Nation, Inuit, Métis, and urban Indigenous adults in accessing cancer screening in Ontario, we have developed an Indigenous Cancer Patient Navigator program, mobile cancer screening coaches, Suluk Out Area Fit Kits on Hand program to screen for colon cancer, and a First Nation, Inuit, Métis, and urban Indigenous cancer strategies are developed in collaboration First Nation, Inuit, Métis, and urban Indigenous partners. Thank you.
Testimony. I would also like to remind all witnesses to speak a little bit slower just so that the ease of our translators, just for the ease of our translators. At this point, I would welcome Professor Danielle. You have the floor for up to 5 minutes. Thank you.
Good morning, everyone. First, I'd like to thank the Standing Committee on the Status for Women for inviting me to reappear as a witness for its study on breast cancer screening for women aged 40 to 49. Just a reminder, I'm a professor and cancer biologist at McMaster University, a 15-year breast cancer survivor myself, and a member of the research subcommittee of the Olive Branch of Hope Cancer Support Services. I have been working with TOBO for the past decade to organize and host Think Beyond Love Pink breast cancer awareness and education workshops and symposia, specifically for Black and other racialized women who consider a breast cancer diagnosis to be a curse or a stigma. The Olive Branch of Hope's mission is to tackle this stigma head-on, since we know that knowledge is power, and we know that an early diagnosis of breast cancer correlates with good survival outcomes. Due to advancements in early detection, screening programs, and treatment options, breast cancer mortality rates have declined almost 50% in the past 4 decades, from 41 deaths per 100,000 women to 21 deaths per 100,000 women now. However, current epidemiological data continues to describe cancer disparities among racialized women that contributes to overt inequities in lived experience during the cancer care continuum, as well as in survival outcomes. Over the past 2 decades at McMaster, my research team has been focusing on the novel protein that I discovered and named Kaizo. Kaizo is implicated in many aggressive human cancers, including breast, prostate, lung, and pancreatic. But more importantly, and what's really interesting, is that Kaizo expression correlates with disparities in breast and prostate cancer outcomes in Black men and women. Oh, got that wrong. In breast and prostate cancer outcomes in Black women and men, respectively, suggesting that Kaizo could be a biomarker for aggressive breast cancers in people in women of African ancestry. My research team is specifically interested in determining if there is an ancestral genetic predisposition or susceptibility to triple-negative breast cancer, an aggressive breast cancer subtype. So TNBC prevalence in West Africa ranges from 40 to 70% in Ghana and Nigeria, and approximately 20% in the Caribbean and the USA, compared to 10% among white women in the USA. What is most concerning about breast cancer in Black women is that despite having a lower incidence of breast cancer than white women, Black women have the highest mortality rate from breast cancer, and Black women under age 50 have twice the rate of death compared to white women. This is in part because there are no targeted therapies for triple-negative breast cancer, which is most prevalent in Black women. In contrast, white women tend to be diagnosed with estrogen receptor positive breast cancers, which are effectively treated with the drug tamoxifen. Because there are no targeted or specific therapies or drugs to treat triple negative breast cancer, or TNBC as we sometimes call it, any woman, be they Indigenous, Black, Latina, white, or Asian, or other, any woman diagnosed with triple-negative breast cancer has a poor prognosis because they can only be treated with radiation therapy, which targets the breast itself, and standard chemotherapy that affects all proliferating cells in the body, for example, our hair and intestinal cells. Canadian epidemiological data, along with data from the USA and the United Kingdom, show that the racial and ethnic differences exist in cancer morbidity and mortality among Black, Indigenous, Asian, and Hispanic populations. As I mentioned earlier, although white females have a greater incidence of breast cancer, racialized women tend to be diagnosed at younger ages, present with more aggressive cancer subtypes, and advanced cancer stages, and consequently all experience earlier mortality compared to white females. Despite this, the current Canadian guidelines regarding breast cancer screening for females of average cancer risk recommend a biannual screening via mammogram starting from age 50 to 75, and they currently recommend against screening individuals ages 40 to 49. The Canadian Task Force for Preventative Health recently released their updated draft guidelines for breast cancer screening in Canada, and unfortunately reiterated that screening commenced at age 50. Both the existing and proposed draft guidelines fail to account for the unique cancer burden amongst Canadian racialized populations and Indigenous populations, and they risk further perpetuation of existing racial and ethnic disparities by underscreening racialized patients and women. These recommendations do not reflect the current practices in provinces such as PEI, Nova Scotia, British Columbia, and the Yukon, where mammography is available for individuals starting at age 40. In Alberta and the Northwest Territories, breast cancer screening is recommended for individuals aged 45 to 74. And this fall, the Ontario government approved self-referral of individuals aged 40 to 49 for breast screening mammography through the Ontario Breast Cancer Screening Program. Although the updated draft guidelines note that Canadian data shows racial and ethnic variability in incidence, mortality, subtype, and stage at diagnosis with younger age cohorts, they state that there's a lack of data regarding the benefits and harms, as well as preferences and values of racialized communities. The task force, therefore, does not appear to consider how breast cancer screening recommendations may be interpreted by racialized groups who typically do not trust the healthcare system, as was alluded to by my other colleagues on the call and witnesses. And this mistrust of the healthcare system is due to historic and continuing systemic racism of Black and Indigenous communities. One size does not fit all, and on behalf of the Olive Branch of Hope, Black Canadian, and other racialized women, I urge the Canadian Task Force on Breast Cancer Screening to revise their recommendations to account for populations at risk for early onset and aggressive breast cancer subtypes. Thank you.
Thank you, Professor Daniel. Next, we have Dr. Caron. You have the floor for up to 5 minutes.
Ani Miigwech. I'm joining you today from the traditional and unceded territory of the Lheidli peoples, which is in Prince George, British Columbia, up in the north. I'm a surgeon and professor at the University of BC, and I'm really joining you today as an Indigenous woman, daughter, mother, sister, auntie, cousin, a member of the Sagamok Anishinaabe First Nation. And I strongly recommend to move or return the breast cancer screening guidelines to commence at the age of 40, as opposed to the current recommendation set forth by the task force of 50. I truly appreciate being here once again with my colleagues from the previous panel on November 18th, so that we can share more of our thoughts and ideally answer any questions you may have that causes you to pause or not support this recommendation. To remind you of what was said previously in November, is there is a difference in recommendations to participate in a screening mammogram program at the age of 50 versus the option of screening mammogram simply being available in your 40s after discussion with the primary care provider, such as British Columbia. Now, there is a paucity of data and research in this field, but there is data, and my colleagues have already shared some of it. The knowledge does exist that supports the need for earlier screening mammogram and improving the rates of screening mammogram participation. In British Columbia, we have a manuscript that is undergoing final review at the First Nations Health Authority that was completed in partnership with BC Cancer and the First Nations Health Authority Chair in Cancer and Wellness. And as I stated in November, when First Nations women are compared to the rest of the women in BC, their breast cancer is diagnosed at a later stage, like Angeline told us, and their survival rates are lower. And these could be addressed with screening mammograms, adjusting to this known data and actually moving to the age of 40. The paucity of specific research regarding Indigenous peoples and cancer is unto itself an entity that needs to be addressed. But I suspect that the persisting inequity in access to health research is beyond the scope of this meeting today. But if we don't have data to support screening mammogram at the age of 50, why can we not start to err on the side of caution unless you have firm proof that you will not be harming Indigenous women by maintaining this recommendation that we are asking you not to maintain? There is some data to support screening mammograms at the age of 40 for Indigenous women, given their later stages of diagnosis and poor survival. But as a researcher in this field, I have seen no data to ever support screening mammogram for women, Indigenous women at the age of 50. Currently, it is recommended that one starts screening mammogram at the age of 50 unless you have known risk factors that increase your risk of breast cancer. This has also been referred to by my esteemed colleagues. And therefore, we should start screening mammograms at the age of 40 if you have these risk factors. These risk factors can be related to family history or genetic test results that increase your knowledge, increase your risk, such as BRCA1, BRCA2, and Dr. Daniels describing some amazing research she's doing to increase our knowledge of what risk factors can be. But these risk factors lead to a barrier unto themselves for First Nations women, because you have to have knowledge that you have these risk factors so your healthcare providers can subsequently recommend screening mammogram at the age of 40. But there is inequity in access to the knowledge of risk factors, given that one's family history for breast cancer or genetic testing results for Indigenous women can be greatly impacted by the legacy of policies and programs in our country, whether it's the residential schools, the 60 Scoop, forced relocation, inequitable access to medical genetics or hereditary cancer programs so that you even know these genetic factors. I think there's inequities upstream that block our ability to have a family doctor say, we recommend you start at the age of 40. In BC, the recommendation is to start at 50, but it is available in your 40s with your first step to be, hey, talk to your primary care provider. But we know that access to primary care is a crisis in our healthcare systems in Canada, and this is worse when considering Indigenous communities, challenges regarding access to primary care, and Dr. Latondra was talking about this in more detail with respect to other barriers. Finally, as an Indigenous surgeon, I see women who have breast symptoms, like a palpable mass. I see women who are referred to due to an abnormal screening mammogram, and I see women who are already diagnosed with breast cancer. I have seen women who are devastated when the diagnosis is late and the outlook is bleak. And I have seen the relief when the results are reassuring, early stage, or negative. Screening mammograms save lives. No one, I think, is denying that. Abnormal mammograms that turn out to be normal have been said to be stressful experiences. But I think we need to start to believe in the resiliency of women and give our voices back. We can handle the stress of an experience of a test or tests that result in empowering results much easier than a diagnosis at a late stage of breast cancer that could have been completely prevented. Chimegwich, thank you, merci.
Thank you, Dr. Karan, and thank you all for your opening remarks. At this point, that does conclude our opening remarks, and I'd like to move to our first round of questions. The first 6 minutes goes to MP Ferrari.
Thanks, Madam Chair, and thank you so much to our witnesses for being here today as we continue to study breast cancer screening across the country. And, you know, the common theme throughout this study, with the exception of the chair of the task force, has been to reduce the recommended age of screening to 40. And, you know, if I can just get through a show of like nodding, like everybody here agrees that it should be, yeah, there's big nods there. And, you know, listen, this doesn't happen a lot in the House of Commons, but I think we all agree even in this room on this. And I guess it's just kind of shocking. You know, many of the women in this committee have their own personal experiences. I know even my colleague who's filling in today, Mr. Honorable Ed Fast, has his own personal experience of his mother being diagnosed with breast cancer. I guess the question comes down to, and I'll start with, you know, Professor Daniel, or Dr. Daniel, I guess it is. Why? Why do you think the chair of the task force has failed to listen to every single expert we have brought forward that has publicly spoken to say, you know, the province has said it should be 40. Why do you think she is not listening? Why do you think, what is the reason there?
You can say professor, by the way. Thank you for that question. I can't see into her mind. I'm not telepathic. But I speculate that her decision and the committee's, the task force decision, was based on the absence of data. And I think what many of us wish the recommendation was that we invested in collecting data and evidence, as well as more anecdotal stories to recognize that there are differences. And maybe the task force was rushed. Maybe they had a tight deadline. As I said, I don't know why the task force and the chair feel the way that they do. And I know that myself and some of the other witnesses found it interesting that one of the reasons she gave for that when she was asked about it is that many women don't like the experience of a mammogram. It's painful. They prefer to not know, and which to me are disturbing reasons to keep the age at the recommended age to 50 rather than 40. Because as I said, knowledge is power. And yes, many of us are afraid. I mean, I was afraid when I found my lump as well. But as a scientist, I knew that it was in my best interest to know so that, you know, the earlier it's diagnosed, the better. So I said, I can't speak to what was going on in her mind. I don't know what the committee discussed, how much evidence they have, but I think they did acknowledge that there is very little evidence. I think what was interesting or disappointing is that there's significant evidence from the USA, and it was interesting and surprising that they weren't willing to use that evidence to guide the the decision or recommendation for the Canadian context. And I know that we like to differentiate and say that we have to do what's best for Canadians, but we also need to recognize that in the absence of data, perhaps we should be using data from another country where they have been doing this kind of research for at least 3 decades compared to us in Canada, where we're not collecting any demographic data on any patient for any disease, not just breast cancer. We're just not collecting it. And that is a huge oversight in Canada. And many of us have been advocating for that for at least a decade. So.
And I think you've touched on something very interesting. I mean, the chair even wrote a letter, like an editorial during this study, doubling down on the recommendations. And,
Yeah.
you know, I guess where I come from this is like, well, where is the accountability of this? Because it seems more malicious than I think you're even approaching, because there's nobody who's denying this.
Yeah.
People's frustrations and survivors really feel like, why have this chair at all? Why, what are the modes to remove her? But also, why no experts or survivors on this task force?
Yeah.
I see a lot of head shaking here because nothing is adding up. And like I said to you, even I'm sitting here and I'm looking at my Liberal members across the way. Like I said, we don't always get grief. That's putting it.
So I mean, I don't know, but who struck the task force? Who selected the members for the task force? Like, I don't. Okay. Okay.
Who's appointing these people, and isn't there a pushback of accountability to do that? And with all of this testimony reversed.
Mm-hmm. Thank you.
Mark, you have the floor for 6 minutes. MP Surrey.
Thank you, Madam Chair, and thank you to the witnesses for your very valuable information today. And I want to thank MP Ferrari for what you just mentioned, because we're in agreement. I mean, the recommendations will be clear about age 40, so that'll be clear. We're also going to have to look at the Public Health Agency of Canada, how they also recommend individuals for this task force. So that clearly we're all in agreement on that. We heard from every single witness except one that that's the case. So I want to turn my attention to kind of the next steps. Obviously, Madame Latendre and Madame Caron, and also from Ontario Health, Madame Kiwash, you mentioned your visits in Northern Ontario, and I want to talk about what can the system improve and the recommendations along those lines. As some of you may know, and I want to talk about the visits, but in Northern Ontario, there's 116 First Nations, 110 are located in Northern Ontario, with 9 fly-in First Nations. And Northern Ontario has the first medical school, NOSM, that's Sudbury and Thunder Bay, in 30 years. They focused on rural and Indigenous. A lot of the doctors that are trained for both, 6 years, also go into the communities. So Madam Kiwash, I wanted to ask, do you have any recommendations along the lines of the primary care training that is happening and what you've seen on the ground with your 2 visits in Northern Ontario? Then I'll ask the 2 other.
Well, in terms of training, we do provide cultural safety training to all of the locum doctors. That's accessible to them. We are working very closely with the Sulico First Nation Health Authority, holds the contracts for locums, and also works with the nurses from the communities, who are federal nurses, by the way, working directly with the community to improve communications and education for community to understand about screening, for one thing, But, there's actually 29 remote communities in northwestern Ontario, and we have been able to bring screening closer to community, providing fit kits, which is the colorectal screening, in the community for them to access, providing mobile screening coaches that goes to Sioux Lookout, so they only have to come to Sioux Lookout instead of Thunder Bay. But there is definitely a lot more work to be done with the primary care providers. They go to communities, they're assigned to different communities. It's not the same doctor. There's no chance to create trust or any kind of rapport with the physicians. We still have incidents of community members not feeling that the healthcare providers are listening to them or just sending them home with an aspirin when in fact they have a stage 3 or stage 4 cancer. I mean, there's things that we are trying to do to make sure that everybody is brought together and is having that conversation. But we do need more supports when it comes to, as my learned colleagues have mentioned, research to understand why cancer seems to be exhibiting at earlier ages for Indigenous people than it does for the rest of Ontario. And we do have some studies that substantiate. We also did an impact assessment to find out what people think of cancer today from a needs assessment we did 20 years ago. And things haven't really progressed all that well in 20 years when it comes to cancer, except people can now talk about it, whereas before they didn't even want to mention the word because there was such a stigma associated to it. Is that
running. And Professor Caron, I won't repeat, your testimony was bang on about the barriers and the early detection and screening and saving lives. But the issue of primary care providers do you have any specific recommendations for us that clearly lack atrocious level of certainty?
Yeah, thank you for that, and I think it's a great question. I am based up in Prince George, which is where the Northern Medical Program is, a very similar model to NOSM, and around the same time, for the purpose of developing a healthcare resource with respect to physicians that want to be up in the north, want to be in rural communities, and are perhaps better trained. At the University of British Columbia, we have mandatory cultural safety training for every healthcare provider student across the disciplines, so not just medicine, but pharmacy, dentistry, midwifery, social work, nursing, dietetics, speech and audiology, across the board. That helps. But I think we need to to keep it really focused on screening mammography. First of all, I have never met a physician who did not start screening mammography in their 40s, even after it was really hammered down that you start in your 50s. I do not know someone who has seen the end result of an undetected malignancy and not detected with a screening mammogram choose to not pursue that. In the data that we have seen in British Columbia, over 30% of women in British Columbia choose that route of talking to their family doctor and getting a screening mammogram at the age of 40. Less than 20% of First Nations women have done that. And I think part of it is the barriers that have been well described by Dr. Latondra and others. So I think part of it is it's kind of sort of sneaking in anyways, but it's really a disparity unto itself about women, even without that firm guideline, that women who are not First Nations, because the data is specifically First Nations in this study that I've done, that actually access screening mammography in their 40s. I think it's a mixed message. So it's actually unfair to healthcare providers. If there's like recommendations and guidelines to start at the age of 50, but consider at the age of 40, or some provinces say in 45, it is stressful. It is hard to explain to, once when you start to hit the age of 40, what's screening and why do you do screening and all of that. So it's stressful. It's hard to explain. It's hard to access. You're dealing with other issues with respect to racism. There's mixed messages. In Ontario, they do this. In BC, they do this. I think we need to get a clear message.
Adrienne, vous avez la parole pour 6 minutes.
you have the floor, Adrienne, for 6 minutes. Thank you very much, Madam Chair. I also thank all of our witnesses for their expertise within this very important study today, because we're talking about breast cancer screening at age 40. And with this time, we have had the opportunity of looking at this question within the context of women's health, and we seem to be unanimous in our thinking. But I'd like to go even further and see if there are any other solutions or ways of thinking. So my first round of questions will be for Madame Letendre. You have talked about the issue of comorbidity and the link between diabetes and breast cancer within Indigenous women. You have talked about the importance of developing more knowledge and being able to choose simple lifestyles. All of this makes me think beyond the issue of breast screening at age 40, which we all agree on, but we can also agree that we have to have other recommendations to make and go even further. I'm trying to understand, why are there so many cancers in Indigenous communities? Because we're talking about healthy lifestyles, we're talking about prevention when it comes to cancer, and the fact that we're not acting soon enough. We're letting people live in conditions that are not appropriate for 2024. For instance, how is it, because we're talking more and more about contaminants and toxins in the environment, and that some communities still are under problems with potable water. So this also can have an impact on the number of cancers in Indigenous communities.
Madame Letendre, est-ce que vous avez...
Yes, thank you.
Madame Letendre, you heard me?
Yes, thank you very much. Really important questions. Thank you for thinking more broadly about the many issues that impact this. I think, first of all, there's accountability on the part of our health systems that needs to be better understood and articulated. Often, as has been stated, their decisions rely on data and the availability of data, but there also needs to be a recognition that I know Juliet talked about anecdotal stories, but from Indigenous perspectives, when these stories are repeated time and time and time again, they are not anecdotal. They're actually evidence. So there needs to be some harmonized data and perspectives around experience of Indigenous women. Indigenous women at 40 are experiencing lifestyle challenges and issues which are often very exacerbated compared to other groups in Canada. This includes the raising of their grandchildren, many of them due to overdoses and what's happening with their grandchildren's parents. I think the other thing that's really important here is what Dr. Caron referred to, and that is the development of resources. Many of the mammograms in different provinces the buses are really old. So the capacity of the system to have up-to-date, really good equipment so we can make it to these remote and isolated regions where we find many of our Indigenous people is really significant. And we also need to look at putting more energy, funding, and research into building community capacity. So when we build community capacity, we can engage provincial screening services at a more meaningful level and with respect to many of the things that you talked about and we've been talking about, such as raising knowledge and information. There needs to be a recognition that when a lot of these resources are going into communities, they anticipate and expect that our communities pull together all of the engagement and take capacity from their own centers and primary healthcare providers to set all of this up. And the level, I think, of evaluation and sharing data is such that it's not very acceptable to communities. And I think we'd probably we'd be able to build the capacity of communities if health systems were more willing to share data, to work towards shared capacity in having these services available. Thank you very much.
Alors, rapidement, il me reste 30 secondes. Madame
So I have 30 seconds. So, Madame Kiriyosh, do you have anything to add to any of these aspects when it comes to the community? For instance, that some communities for instance, what could Chalk River, for instance, do when it comes to water supplies, and could it possibly affect the cancers there?
We do know that there are a lot of environmental contaminants in community that are likely at putting people at risk for certain cancers, because we do work with the Occupational Cancer Research Unit at Ontario Health, and there's a lot of studies to substantiate that. So when it comes to communities and the high number of cancers that we're seeing, likely there are certain culprits for sure that have to do with contaminants. But the other part of that is poverty, food security, just not having access to healthy foods, not having access to recreation opportunities, not being able to get out of the land because of the high cost of gasoline, and people just can't afford to keep their skidos going, or even going out in the boat to hunt for natural game and fish, which we know is a lot healthier than store-bought meats. I mean, doing natural harvesting, those activities are out of the reach of most community people. So certainly more resource and more understanding of how we can support them to do those types of things would go a long way to helping people to be a lot healthier when it comes to nutrition and physical activity, as well as emotional well-being.
Next, I would like to welcome MP Ilau for 6 minutes.
Thank you, Chair, and thank you to the witnesses for appearing today a second time, I understand, on this study, a very important study. My first question will be to Alethea Kiwayush. Sorry if I mispronounced your name. I understand that based on the previous meeting, there had been some discussions leading to racism in the healthcare system and how a lack of access to healthcare is placing Indigenous women more at risk and not being diagnosed at earlier stages of cancer. And I wonder if you could briefly expand on that, Kuya Nami.
Yeah, you only have to pick up a paper and see different incidents that are happening in hospitals across Canada. But in Ontario, we have recent incidents of racism happening in hospitals across the province. Some incidents leading to people not surviving. We do know that, we feel that if there was a bigger penalty applied to a racist incident, that those incidents would probably stop. But people get a little slap on the wrist, or they're told not to come back to work for a few days and nothing happens. So community know this. They know that, if there's a situation occurs, they're not going to be the ones that are heard. We do have the Patient Ombudsman Office that we've been working closely with to put in a Indigenous Early Resolution Specialist position, and that's helping. We've also been working more closely with the Ontario Human Rights Commission, but the fact is the other part of that is education and just creating understanding across hospitals when it comes to cultural safety. And we work closely with partners like the Indigenous Primary Healthcare Council, and they have done cultural safety training that helps to show people what's appropriate, what's not appropriate. I think a lot of it is based on ignorance. People just not understanding, when they say certain things to Indigenous people, how offensive that is. And I don't think it comes from a place of malice necessarily, but ignorance. So we need to do more to educate the healthcare system and healthcare providers to cultural awareness, cultural safety. And we are working to do that, but the onus is on them to step forward as well. And the other part of that is there needs to be resource so that our healthcare system can afford to take time away from their incredibly busy schedules to take this type of training. But I think it's really important that people understand what the true history of this country is and the role that First Nations have played and the other nations as well. But most people don't. A lot of the folks in the healthcare system are newcomers to Canada, and they don't have any concept of the history. So there needs to be more done to improve understanding of the history of Canada and the role that Indigenous people have played and the historical traumas that have been perpetuated on them, leading to what we see in communities today. People still struggling to break free of that and to come out from under the shackles of, the residential school, the discriminatory policies in the Indian Act. There are so many things that are still in place today that it's hard to come out of that when they're still there. But I would say that Indigenous people are incredibly resilient. And from 20, 30 years ago, where they would just accept what somebody told them, they are now standing their ground and saying, wait a minute, I'm not going to take that from you. So we are doing our bit to make sure that we're pushing back on those types of behaviors as well. And I see communities stepping up more and more to that.
Thank you so much. You naturally responded to my follow-up questions that I was going to ask regarding ensuring that the healthcare system is more trauma-informed about Canada's treatment to Indigenous peoples. Of course, you mentioned, for example, the residential schools in the high Arctic. We have the dog slaughters and things like TB, as well the current system. I wonder if you could speak to how the current system is having a negative impact on Indigenous women's health, like the lack of investments in housing, the lack of investments in infrastructure, and how that impacts the ability for Indigenous women to seek breast cancer screening.
Well, one of my colleagues mentioned that most screen-eligible women who, 50 and up, and in Ontario, 40, if you talk to a primary care provider, can get screened. But we have women that are not only looking after their grandchildren, they're looking after their great-grandchildren. They're trying to put food on the table. They're trying to keep a roof over their heads. Getting screened is the last thing that they're thinking about because these are the issues that they contend with every day. We have communities that are all struggling to try to make ends meet. And where does breast screening, where does any kind of screening, where does any type of self-care come into place? We have high rates of diabetes, as one of my colleagues mentioned. We have all kind of heart disease. I mean, when it comes to health issues, we have them all. It'd probably be easier to identify as the ones we don't have than the ones we have. So how do you prioritize, healthcare and self-care when you are dealing with these day-to-day struggles and trying to feed your family, look after the grandkids, look after the great-grandkids, deal with a family member who may have taken a path, that leads to unhealthy coping mechanisms, such as drug abuse or alcohol abuse. I mean, these are the realities in communities.
Dominique, vous avez la parole pour 5 minutes.
Dominique, you have the floor for 5 minutes. Thank you very much, Madam Chair. We're learning today, but we're learning that the mental burden for women has no bounds. It's everywhere. Madame Kawayosh, you have said that this mental burden of grandmothers and great-grandmothers are huge, and their burden. Women have these burdens every day. So thank you to this incredible panel for everything you've said today. I know how busy you are. You are women saving lives. We don't do that, but you do that on a daily basis, and I thank you. I am quite upset angry about this recommendation that was made, that the committee is maintaining. At least this is a signal that we are receiving. And it seems that this committee is quite against the recommendation to maintain systematic screening only as of age 50. What I want to tell the committee today, and I know that some of my colleagues agree here, is that make the service available and let women decide on their own. Let's stop infantilizing women. When women go see a doctor because they have a UTI or they have menopausal symptoms and they know their own bodies, women know what is going on within themselves. And it seems to me that this screening should be available to women because it's their bodies. They need to decide, do they want to have a screening? Do they want to have a mammogram? Do they want to have a breast screening? I just can't believe that in this day and age that someone can maintain that women do not get diagnosis because they might be afraid of what they might see. They might be afraid of what they're going to hear because they might be anxious or stressed. I mean, unreal. I can't believe this. There are women around me, younger, older, who've gone through all of this. And there's not one of these women who is not thanking God right now because they were able to get a screening and they were able to get the correct diagnosis earlier. And we know that it comes to early diagnosis with breast cancer, things go well. It can be. Well, anyway, Madam Daniel, when you say to me that you think that the chairwoman doesn't want us to know, no, nobody said that during the study. Nobody says that here in the committee, and I'm sure that this is incorrect. Now, Madam Kewayosh and Madam Daniel, now, if I understood from what you said today, and Madame Kewayosh, I do hope I'm saying your name properly, because you said at the first meeting that we had that everything that has to do with cancer and breast cancer is a very much a taboo subject in the Indigenous communities. And sometimes that's why some women don't want to go ahead with a screening or a diagnosis. And Professor Daniel, you have also said that there seems to be a kind of a curse or stigma you've mentioned. Do you think that this barrier could be removed? Let's say with awareness campaigns or communication campaigns. And my second question is, have you gone to see the government or other institutions or authorities in order to be able to face up to this problematic? Let's start with Madame Kewayosh, if you don't mind.
Yes, I believe that we can improve upon the understanding of what people think of cancer today, and we have done that in Ontario for the last 15 years. We have launched a massive communication education campaign to help communities better understand what cancer is and what they can do about it. And fast forward to today, 15 years ago, where people wouldn't even talk about cancer, and if they did talk about it, all they knew about it was a death sentence. Today, we have communities asking us to develop survivorship programs because they are now seeing people surviving cancer in their communities. And to me, was so heartwarming to me because we're working so hard to get them to that understanding. Is it across the board? No, we still have a lot of work to do. But for communities to now see themselves surviving cancer, that was a major development, and that was, I think, a result of a lot of work to help increase the understanding of cancer in communities and take away the fear from that word, and we are moving in that direction. So yes, I believe that we can take that stigma.
Sonia, you have the floor for 5 minutes.
Thank you, Madam Chair. Thank you, all the witnesses. We heard in this committee reliable data, education for cultural safety. And my question is to Dr. Karen. Dr. Karen, last week, Minister of Health announced funding for research into breast cancer screening, including treatment and outcomes by race and ethnicity. You also mentioned lack of data, specifically on triple-negative breast cancer in Indigenous women. How we can bridge this data gap and we can ensure women are getting the care and access to breast cancer screening which they deserve.
Thank you. That is a great question, and it's great to hear. That one question or one answer to that is you can't do it about Indigenous women, Indigenous people without Indigenous people. It can't be done. It will never be done successfully. That's a yesteryear. That's a historical response. That's number one. I think number two, then you're tapping into Indigenous scholars, physicians, healthcare providers, researchers, and given the historical approach to education and marginalization of Indigenous peoples in this country, that is a relatively small pot. So we have to acknowledge that and support those that are willing to go into that space. I think third, we have to recognize and not lose sight of the fact that this data has been absent. We have a little bit of data, and then be patient to wait for it. But by patient to wait for it, I really cannot stress enough that we should not have to prove that we need this. If the government and the funding bodies in terms of the health systems that would pay and fund and resource the screening mammogram, for example, the burden should finally fall on them, the healthcare system, to prove that Indigenous people will not benefit from this. It's always sort of like the data needs to be there to prove that the resources are warranted when you're hearing it repeatedly. As a First Nations physician and a breast cancer surgeon and a breast cancer researcher, I hear it ad nauseum. And why? While we don't have the data, because we haven't had the resources, because we don't have the education background based on the residential schools and all that, the patience needs to be, until we know otherwise, we're going to be very cautious and value Indigenous lives in this country. And I think the final thing that's really emerging now is Indigenous data sovereignty. And so when we generate the data, when we start to get this knowledge and we move together as a country in our healthcare systems and in our public health systems, I think what we need to do is we need to recognize that we need to protect the sovereignty of this data that is owned by Indigenous peoples and should be guarded by Indigenous peoples so that we know how that data will be used is very important. And how do you do that? I go back to my original answer, not without Indigenous people to actually help direct that. And I think we're at a place really where as an Indigenous researcher and healthcare provider, I trust that with the right people in the room, the whole room doesn't need to be Indigenous people. I'm hearing all these questions, these brilliant responses from these elected officials, and you guys sound like you're listening. You sound like you care. You sound like you're hearing us. So you don't need to be Indigenous to care or to understand. But I think we need to move forward as a country, as a community. And I think the fact that you asked this question is in itself a step forward.
Thank you. But I want one more follow-up question on that. We heard one of our witnesses last time, Janie Dale, noted that women often face a power imbalance with doctors. This makes it difficult to push back when their doctor refuses to refer them for screening. What has the impact of this power imbalance been, particularly the women of color or Indigenous women or racialized women?
Mm-hmm. So absolutely. I think actually we can kind of take the adjectives off. And I think women in general tend to have a power imbalance. I feel that as a surgeon when I walk into the room and I'm surrounded by, if there's like male colleagues, I think it's improving, but it hasn't gone away. When you add the power imbalance of a patient with a healthcare provider, with the belief that the healthcare provider, having spent those years studying and learning that, and the patient not really thinking about breast cancer day in, day out, if that's not their field, there's a power imbalance of knowledge that is there. But if it's magnified by stereotypes, by bias, by racism, by gender or sex inequity, or power imbalances that way, I think it magnifies this. I think, as Althea said, I don't think that should be tolerated. I think that there should be significant ramifications from it. I strongly urge, if you're looking for like this concept of racism and is there data, during the pandemic, the provincial government launched an inquiry into Indigenous specific racism in the healthcare system. This was not related to COVID. It wasn't related to vaccines. It wasn't related to PPE. It was literally related to everything in our healthcare system. And in the middle of a pandemic, it became an urgent inquiry into what is going on into our healthcare system. And it's not one story, one patient, it's an entire population in an entire healthcare system that I no doubt mirrors the rest of Canada.
Dr. Caron. Adrienne Larouche, you have the floor for 2.5 minutes.
Merci beaucoup, Madame la Présidente. Encore, merci à nos...
Thank you, Madam Chair, and I would like to thank our 5 witnesses for appearing here this afternoon. So for my second and probably last round, I'll start with Ms. Danielle. You talked about something which of course we had heard before, but each time this is quite striking for me. You talked about markers, and if I heard this well, and you can correct me if I'm wrong, Ms. Danielle, you talked about 40 to 70% of them in West Africa. So cancer biomarkers, is that what we're referring to? And 20 to 22% in the US and 10% in Canada. First, did I get the numbers right? And did I really understand those statistics?
So thank you for that question. The statistics that I mentioned are basically is the incidence of triple negative breast cancer, not the biomarkers. So the incidence of triple negative breast cancer ranges from 40 to 70% in West Africa, 20 to 25% in the Caribbean, which is relatively homogeneous Black, and then similarly 20 to 22% in the US. But in white women, the incidence of triple negative breast cancer is only 10%. So based on the research that I'm doing in my lab, we think that there are unique genetic mutations or epigenetic marks on our genomes that are predisposing Black women to this aggressive breast cancer subtype compared to white women and other women. However, what I also wanted to point out that we didn't get to talk about much today is that, again, from studies in the US, they have found that racism is a social determinant of health. And there are studies and researchers in the US who are examining this at the molecular and genetic level. And what they found is that racism can actually, like continued perpetual racism, can lead to epigenetic changes on our genome. So they're not mutating the genes. They're simply these epigenetic marks. You can think of them as a tag, whether it's or a tattoo that goes onto the genome. And that slight modification is not changing the DNA sequence, but it's changing the way that our genes are then expressed. So in some genes, they could be turned off when they should be on, or they're turned on when they should be off. And so that's a booming field of research that's growing. But we do need to identify those biomarkers and those epigenetic marks in populations that have been historically traumatized and oppressed by racism, because that would shed significant light into why they may be having, or we, I should say, not they, we, including me as a Black woman, may be having or being predisposed to these very, very aggressive types of cancer.
MP Idlout, you have the floor for 2.5 minutes.
Thank you, Chair. I'll be asking my question to Dr. Latendra. I wanted to ask, to divert my question a little bit away from the importance of distinctions-based research or care. I understand how different and completely agree that we need to make sure that First Nations, Inuit, and Métis are included in all of this work. But I wanted to amplify the opportunity about ensuring remote communities are being amplified. So I wanted to ask you very quickly if you have read a study called Perspectives of Nunavut Patients and Families on Their Cancer and End-of-Life Experiences. The study was conducted by Tracy Galloway, Sydney Horlick, Maria Cherba, Dr. Madeline Cole, Roberta L. Woodgate, and Gwen Healy Akero.
Yes, thank you for that good question. Yes, I have read that study. As the vice president and the research chair for the Canadian Indigenous Nurses, we represent, or I shouldn't say represent, but we work with all three distinct groups in the country. We actually are celebrating our 50th year anniversary this year. We are the oldest healthcare provider organization, both Indigenous and non-Indigenous in the country. We've done some really, I think, groundbreaking work with primary healthcare providers. We worked with Tutit, Inuit Women of Canada Committee, quite closely on this, and were able to support them to do some information and data gathering with Inuit communities that they work with, but also with healthcare providers. Much of our work, and we're going into phase 2 of that, is working with primary healthcare, national Indigenous primary healthcare organizations. We started out with the friendship centers, social workers, physicians, and of course the nurses. And now we're going to be expanding to try and work with pharmacy, occupational therapy, the Indigenous Dental Association. And what we found from our work that the Indigenous healthcare providers, the primary care providers, are facing as well multiple challenges in trying to address the cancer and cancer prevention needs of Indigenous communities and certainly Inuit and Northern. Thank you for the good question.
For the last two members, instead of 5 and 5, we're going to do 4 and 4, just to shave a few minutes so we have the room for the second part of the meeting. And Michelle, you have the floor for 4 minutes.
Thanks. Thanks, Madam Chair. And again, thanks to the witnesses' valuable testimony coming from, the years, decades of experience that we have sitting on these panel of experts, expert testimony. I have a fairly pointed question. Because as I've sat here and thought about how this is playing out, a lot of it doesn't make any sense to me. And my colleague, Ms. Vienne, she is so articulate in what she said about women being able to advocate for themselves and being able to ask for what they need. But unfortunately, a lot of the problems is a lot of people don't even have access to doctors in this country. That is one of the big issues for sure. But I'm curious what you guys would suggest in terms of this task force and this chair. We have to put together recommendations from this study. Would you ask for the resignation of this chair? And I can, whoever wants to start. I'll go with Professor Daniel.
I would say my recommendation would be for dismantling of the task force and having a completely different task force with membership that's representative of the Canadian population that they're serving, so that there's diverse membership on the committee representing having, for example, Indigenous and Black breast cancer oncologists and physicians, Black and Indigenous cancer researchers, biologists, cancer survivors, cancer caregivers, because not I think we don't get the perspective of the caregiver of the cancer patients often enough, and that's a valuable perspective to have in these decisions. So not necessarily the resignation of the chair, but I think the entire committee should probably be dismantled and a new task force struck that will approach this from the lens that we've been discussing for the past hour plus to an hour a couple weeks ago.
I'd like to hear anybody else's answer to this question too, hopefully if we have time. But do you think if you have provinces that are even doing this job, that are overseeing this, and you have provinces already kind of doing their own thing, do you think a task force is just another arm of bureaucracy?
It is. It definitely is. And I think for many of us, that's probably one of the questions we had. Why do we have a task force when every province seems to be doing their thing? But as a settler immigrant in Canada, that's been one of my challenges, seeing how our provinces tend to be responsible for health and education, but then the federal government also plays a role in that, and they don't get along. But that's a whole different story. So it is a challenge. And for example, when I was diagnosed, I couldn't get my mastectomy with reconstruction at the same time. The only province that was doing that in 2009 was British Columbia. And that was when I realized that there were discrepancies in our healthcare system, that as a Canadian, I wasn't privileged to be in the right province at the right time when I was diagnosed. And to me as a Canadian, it shouldn't matter where a Canadian lives in Canada. We should all have access to the same healthcare. It should be equitable regardless of the province we reside in.
Does anybody, any of the experts, the resignation of the task force chair?
I don't know who she is or he is, but they're obviously very out of touch with the topic. And I'm sure there was a task force struck at one time that created residential schools. And look how well that went over. So they need to be more in touch with the topic. They need to have understanding of what's happening with community, with people. They need to have their pulse on the hands of what community are saying, what people are saying. So they're very out of touch.
Thank you. Emanuela, you have the floor for 4 minutes.
Thank you, Madam Chair, and thank you to all of our witnesses for being here with us today to answer some more of our questions. A few of the witnesses today spoke about the role, perhaps, that intergenerational trauma plays in this, especially with Indigenous and Black Canadians. And then I know Dr. Daniel spoke a little bit about epigenetic changes and just, changes in genes due to stressful situations. I've also had people who have had experience with cancer at a young age who were white, but who had it very early on and very aggressively because they've had very severe trauma in their early life as well. So based on what you've been looking at, Dr. Daniel, and if anyone else wants to chime in here as well, would you recommend that we recommend any on including taking a look at how trauma and I guess epigenetics plays a role in this? Because I think that, different communities. We would be tackling Indigenous communities, Black communities, but generally all women who have maybe experienced significant stressful.
Yep. Thank you. That's a fantastic question, and I know we're short of time, so I'm going to say yes. I would recommend that we have a study, a longitudinal study, or clinical trial, is depending on how it's done, that looks at the impact of environmental factors, racism, the social determinants of health and trauma on women. And the study that I referred to in the US was actually based on a longitudinal study looking at women who developed chronic disease in their 40s. And the only evidence or the only factor that correlated with the development of a chronic disease in between the age of 40 to 49 or to say in their 40s, in their 40s, was having a trauma, and that was irrespective of ethnicity. So to your point about younger white women also having breast cancer at a young age, it was definitely linked to a trauma before the age of 10. So if a woman has experienced any kind of trauma before the age of 10, whether that is the loss of a family member, a parent, being in a car accident, anything that's incredibly traumatic before the age of 10, that correlated with the epigenetic changes that were seen on their genome and having a chronic disease in their 40s, whether it be diabetes, cardiovascular disease, or cancer. So I would recommend that we engage and look at the data coming out of the US where they're doing these studies so that we don't have to reinvent the wheel. We don't have to reinvent the wheel. We can use some of that data in our Canadian context and do it faster and better.
So much. Do I have any more time? I have a minute left. Okay. Dr. Karen, would you like to chime in as well? I know you spoke about intergenerational trauma. I know so did Kiwayosh. Dr. Kiwayosh, if you guys want to chime into that, you can.
Thanks. I know we're very, very short on time. First of all, ditto to Dr. Daniel, and thank you so much for asking this a question. I agree with everything. The one thing is this will take time. We cannot wait. We've heard it, we believe it, we think it. I've been to hundreds of First Nation communities, Inuit communities, Métis communities. I hear it repeatedly. I think what we need to do is move upstream, fix it, and then ultimately prove that we were right rather than having more lives lost and then say, geez, we should have started that earlier. And that's what I've noticed over my career in the world of cancer in particular.
I feel that
that does conclude our panel for today. And on behalf of the committee, I would certainly like to thank all of the witnesses for their testimony. At this point, we will be suspending for approximately 5 minutes to transition into camera portion of today's meeting.
Thank you.
Thank you, Miigwech.
Thank